Welcome back, everyone, to the Basics of Insomnia Part 2 with Dr. Barry Krakow. I just wanted to re-mention that Dr. Barry Krakow has some excellent books on sleep, insomnia, sleep disordered breathing, which I have personally read and quite enjoyed. And also that I will leave all of Dr. Barry Krakow's contact information if you're interested in working with him professionally. He does sleep coaching and some other things as well, so you can check out his website below. Enjoy the conversation.
I don't even know if they get to see many of these cases. The people who see them a lot are mental health providers. And of course, they throw their hands up because they don't know what to do other than give more pills. And those are very sad cases. And
Sorry.
those are very sad cases, and not a lot is done to help them. They take months or years to get through. And I'm only giving the example to show you how severe this can get if you wrap up all your mental health problems into your insomnia. That individual is going to go, oh, well, I never get sleepy. I'm always tired. Your techniques don't work. You need to give me a stronger drug, something like that.
Am I conceptualizing this correctly that in almost all cases of insomnia, it's has to do with mental health or at least some
Yes,
entanglement of emotions,
absolutely.
or is there also,
Absolutely.
yeah?
Absolutely. If we're talking about chronic, but
Right.
even an
Oh,
acute
sorry,
in a
sorry.
certain way. Oh, go ahead. Go
What's the
ahead.
difference there, chronic and acute?
Right. So acute is the person, they lost a loved one and they can't sleep for a couple of weeks. I mean, it's really, they're in mourning, they're grieving. Their whole life is disrupted in any number of ways. Like, why wouldn't their sleep be disrupted? Some of those individuals, that type of insomnia is very disabling, and they need sleeping pills. And the sleeping pills can actually help them, assuming they don't become dependent on them and say, well, I need sleeping pills now for the next 2 years. But in that short run, it can really break that cycle. They can start to function a little bit better. And then maybe a couple of months later, they're no longer taking the pills. Their sleep is back to its normal pattern and so forth. So that's that acute phase. And acute insomnia is important because there are many people, obviously, who go through traumatic experiences and some of them just don't cope well. And if that pill is going to make them cope better because they get some sleep during that period, then I'm all for that. And people in sleep medicine have been preaching this for decades, that acute insomnia is absolutely an indication for the appropriate use of sleeping pills. Chronic tends to be anything after 3 to 6 months. But in general, if you're going to meet somebody, like if you're a doctor or a therapist, if you're going to meet somebody who's got chronic insomnia, they didn't have it for just 6 months and walked in the door. They've had it for 6 years, or they've had it for 25 years. They had it when they were a kid and remembered it, or they had it as a teenager when they were in high school and getting bullied, or they had it in college. And then maybe it went away for a while, but then it came back again. So most of these people have very chronic timelines that are extremely different than the acute pattern we described a moment ago.
This is a little bit of an aside. We're going to come back in, but how do doctors figure out what sleeping pills to start a patient on? I've never really understood this. It's my general impression that X sleeping pill may not work on Y person, but does work on Z person. And so, how does it, like, imagine a patient comes in brand new to a sleep doctor and they have acute insomnia. How does that doctor decide which of the sleeping pills, which there are many, to give that patient? I've never understood that. Is
Well,
it a
given my
preference?
given well, given my prescribing history is so limited, like the total number of people I have prescribed a sleep aid to, a sleep aid, even like, recommending an over-the-counter antihistamine or something like that, is so limited that I can't in any way say I have expertise in this area. I can tell you from dealing with so many people who come to me who want to get off of pills and so much that I've read about in the world of sleep literature, that there are short acting agents like Ambien, as the best example, that people often get prescribed from the get go. Like somebody will give them 5 or 10 milligram pill and say, break it in half. take a really small dose and, see what happens. Um, but the problem is that these drugs don't work long term very well. Many people who use these drugs eventually just stop using them because they don't work anymore. So I just stop using it. But then if you have more severe insomnia and it becomes more chronic, then they go and they see a doctor and say, well, can I have then the new drug? Can I have the different drug? And then they go another couple of months or a couple of years, like, well, this one isn't working now. Can I get now another drug? So that's how those people, and that's a certain small contingency. Just keep this in mind. The typical person who tries a sleeping pill doesn't stay on it. They can see at some point that it makes them sick. They don't like it, doesn't feel that good, gives them some kind of side effect. They don't like the idea of being on the pill. They don't want to be on it long term. They don't even think it works long term. So they just stop it. So that's good news. That's good news. So, but there are, unfortunately, a contingency of people who have this problem of hypnotic dependency that isn't then just the sleeping pills. It's lots of other psychotropic drugs. And so that's when I see these people that have severe insomnia, they've been on trazodone, Seroquel, and Ambien, and another benzo, and they are on all of them. They say, well, why are you on all of these? I say, what are you treating? And some of these individuals say, well, I think we started out with this for the depression, but now I think these drugs are mostly trying to help me sleep. So they're being very honest, and they had an honest conversation, with their prescribing doctor that they're just loading them up with more and more things that somehow is going to solve the problem.
Okay, so I'm trying to walk the path of someone who's been diagnosed with insomnia, which I don't have. Maybe I've had it at a few periods of my life where which we can get into in a little bit, but when sleep disorder breathing gets really bad, I think that there's probably a psychological component that sneaks in sometimes, and now you're super worried, therapy's not working, etc. But okay, I'm an insomnia patient, chronic. Let's just say it's been a while, at least a year. And I come in and we do the conversation. Uh, it's not really doing anything for me. We do some CBTi. What's next? Is there something else for these people? Do you go back to having more conversations at a different angle? How do
Right.
things work from there?
Well, the most important thing to do first in that situation, which is sort of common for me, but also for other sleep professionals, because they often see people who have failed like sleep hygiene or something that was called CBTi, is to go through what was the CBTi thing that didn't work? Like, what did you actually try? There's so many different variations of how CBTi can be delivered, and it's, of course, in the age we talk about personally tailored medicine, we think is happening. We think it's going to be the new wave, but the way healthcare is being delivered, it kind of is an obstacle to that. I think we've talked before about, my belief is that eventually a large contingency of healthcare will no longer be related to insurance. People will be able to speak with doctors or your doctor AI assistant or something that allows you to have longer conversations, which is what you need if you're going to be able to deal with something like insomnia. So, in that framework, what will happen is you'll hear something like, well, they told me not to look at the clock. It's a classic example of CBTI. So, you didn't look at the clock. Is that right? Said, well, I actually took the clock out of the bedroom. Oh, well, that's really good. So did that help? And the person, being candid, goes, well, um, I mean, it was sort of hard at first because I was used to looking at the clock and trying to figure out how much time was left and whether or not. But then I realized I could just listen to the birds outside, look at the light coming in the morning, and I said, oh, well, now that's really interesting because you have been engaging in time monitoring behavior that we call more external to you. Like you're taking cues outside of you from the environment and bringing that information and using that. That's actually no different than looking at the clock. So the individual goes, gosh, you're right. I didn't realize that because I do get caught up in that. Like, oh, yeah, that the light hasn't come in yet. So maybe I've got another hour left. So let me try and go back to sleep and then look again. Oh, the light is coming in. Oh, what do I do now? You're right. It's just like looking at a clock. So it could be that when the person who gave the CBTi instruction said, okay, you've got to get rid of the clock, the person thought that that was a good idea and they thought it was going to be challenging. They didn't know if they could do it, but then they reverted to something else without making the connection, the insight that that's also time monitoring behavior. Now, when you have that kind of insight happening in real time in a personally tailored session with an individual, and they hear that, they go, that's really interesting. So I actually heard an instruction that made a lot of sense to me. I applied it, but then I went about doing a self-defeating behavior. They might not use all these terms, but something close. A self-defeating behavior that's just like the thing I said I was going to fix, but really I'm doing the same thing. And now I understand I have to pay more attention to this if I really want to treat my insomnia. You're saying that if I'm in bed and I want to think, I have no business being in bed. And I have to commit to getting out of bed and reading or doing a puzzle or whatever. And I say to them, well, that is one possibility. But the other possibility, and now we're talking about, just to be clear, usually several sessions later, or sometimes several months later, depending upon the growth in the individual. I said, you know, you can solve insomnia anytime you want in the middle of the night if you learn one of two basic skills about the way the human mind works. And I know you've read about this in my book. I've written about it in the Sound Sleep book and in the Life Saving Sleep book, that if you're lying in bed and you're thinking, well, that means you're not feeling. And it also means you're not picturing stuff in your mind's eye. And it turns out that sleep is often related to falling asleep, is often related to pictures in your mind. So if you wake up at 3 o'clock in the morning and you can't get back to sleep, there are two techniques you can learn. I can't say the word they're fail safe because I don't know how well you can learn the technique. And it may take months or longer to learn the techniques because of the way you have groomed yourself to be an intellectual. Because that's basically what all insomniacs are. I always think of insomniacs as being higher IQ'd and too intellectual for their own good. But if you can learn to picture things in your brain, actually see images, a nice vacation, a trip to the beach, there is a chance that will make you drowsy and you'll fall back asleep. The other one, it's the hardest, but it can be done, is if you actually wake up and you go, I know it's bothering me. I know what happened 2 days ago, a week ago. I know that that phone call that I had with that guy that so pissed me off. And I've just been thinking about it ever since. And I've never really asked myself, what am I going to do about it? What's my response going to be to it? And now here I am. It's 3 o'clock in the morning. And now I'm actually feeling that anger. And I'm feeling that frustration. And I am doing what? I am being honest with myself. This is what is going on. This is what's causing my insomnia. Person could get up and go, all right, well, then I'm going to get up and I'm going to go do something else. But you know what else they can do? They can actually process that emotion. They can actually say, wow, I've been running from this. I've been running away from this. This is what it is. Gosh, I feel so much better that I am not letting that get to me now. I can now say, this is the problem. I have to address it tomorrow. I will write down my response and show it to a friend so they can tell me this isn't over the top, blah, blah, blah. And I feel so much clearer now that I know what this is about. I think I'm going to go right back to sleep. And you do. So when I say this, it's very important to hear that what I just described is exactly what normal sleepers do all the time at some point in their life. Meaning, there are so many millions of people who are normal sleepers, but they're also pretty decent at processing emotion. They wake up in the middle of the night and they go, hey, what's going on? And now they remember the incident and they go, oh, yeah, had that argument with the mother in law. Boy, that was really stupid. Wow. Um, okay. I'm gonna be having to make some amends tomorrow. So we'll get on to that tomorrow. Next thing you know, they go right back to sleep. So that's how emotions work. The people are afraid of emotion and don't realize that emotions are there to give you these very important messages that help you survive, that help you persevere, that help you grow. And a normal sleeper does just that and therefore never says, oh, I have insomnia. It would never occur to them to have insomnia.
Is this what you say to most people who do wake up in the middle of the night? Am I understanding correctly? Either try to imagine something by distracting your mind, it sounds like, or consider for a second something that might be bothering you. Are there other things to do, or are those kind of the two big things?
Well, it's all about personally tailored approaches. Because if I don't think somebody's ready to hear those two things, there's no way I could say that. So a more standard routine is, can you get them involved in learning the construct? Well, do you want to be in bed not sleeping? Do you think that's a good idea? Do you think it's possible? Like, would you be in bed doing your tax returns? Would you be in bed um, reading schoolwork? Would you be in bed trying to do something that's not about sleep? And they look at you like, yeah, I guess that does sound kind of dumb. So I guess, yeah, you shouldn't really be in bed unless you're going to be sleeping. See, that's such a huge thing because there are so many insomniacs who think one and only one principle. The bed is the place to sleep. Therefore, if you want to get more sleep, you might as well stay in the bed because the longer the longer you stay in the bed, well, then obviously you get more sleep. So because so many insomniacs think that, you can't just like say, okay, get out of the bed. You have to go through a discussion point with them, and that particular discussion point can take one session, it can take 2 years. And I've seen patients of both type where they've come to me and they've said, oh, yeah, they told me that 2 years ago, but that didn't work. I said, okay, well, tell me more what you mean about it didn't work. And so you know that, again, this whole thing about the emotional processing was never discussed. The concept of how the imagination was never discussed. The whole discussion point about, do you realize that you keep demanding that you deserve this sleep, therefore that bed is going to deliver the sleep, and therefore, uh, damn the torpedoes, you're getting into bed. It hasn't worked. Have you convinced yourself yet that it hasn't worked? Because now maybe you're ready to hear this point, and we can go on now to the next step. So, regarding the emotional processing and the imagery techniques, that tends to be somebody who's either at a tipping point, who's tried everything and it doesn't work, and they go, you know what? I'm really open to new things now. I want to hear anything. Tell me anything. And now they immediately want to have the discussion about what's going on in your life. And so that person's going to be ready. But a lot of other people, that's downstream before they can hear that kind of stuff.
When does the recommendation come into the conversation to get up out of bed? Admittedly, now that I think about it, a little bit earlier in the conversation, I wasn't sure if I had insomnia, but I guess this would count. There are some times when I can't fall asleep, and then I think, you know what, all these sleep experts say, get out of bed because you're training yourself or something to not
Right.
sleep in bed, which is bad. When should someone do that? And how long should they do it? What should they do? Is it even true? Is this a bad idea, a good idea? Does it depend on who
No,
it is?
no, no, it's a crucial idea because, again, we're talking about chronic insomniacs. The acute environment is very, very different. Um, it's not exactly sure. It can be so idiosyncratic with each individual in the acute environment. There's almost no general recommendations you can make. But for the chronic insomniac, it's first of all, it's going to be how would you feel if you had to get up out of bed? Before I even say anything about getting out of bed, I'd say, how would you feel about getting out of bed then? And now the person's going to reveal to you the construct that's working in their brain. If the construct is getting out of bed, why would I do that? I mean, that's ridiculous. Why, like, did I come to the wrong place? And so if you get an answer like that, you're going, oh, that's really interesting. So you think the more time you spend in bed, the more sleep you're going to get. Right. Yeah. Okay. Well, that's an interesting idea. And that could be true for some people. Has it worked for you? Did you make that work? Do you find the longer you spend in bed, the more sleep you get? And your answer could be, oh, yeah, because what I do is I spend even more time in bed now. So now I'm up to 12 hours in bed. Okay. And what do you get? Well, now I get 5 hours. I only used to get three. And so you see, there's people that can actually go down that pathway. So again, you can see that if you're going to have that discussion, that construct is deeply embedded within them, and you can't just throw it on them. Well, you have to change this whole behavior, blah, blah, blah. That's why I mentioned the thing before about, well, can you change 15 minutes? Can you change 30 minutes? Something like that. But it is absolutely true that the concept of being in bed is related to a deeper emotional, psychological process that I've described a great deal in this book, Sound Sleep, Sound Mind. And that is virtually every insomniac, in addition to the concept of unfinished business, usually has alongside of that a lack of satisfaction with something in their life. Now, you could say those two things sound like the same thing, and they could be. And they may be just, opposite sides of the same coin. But many insomniacs, when you first ask them about emotions, it's very obvious that there's some anger and frustration going on in their life. There's something they're angry about or frustrated. There's a standard rule in sleep medicine that says, well, if you get up out of bed, go do something boring, like watch a boring TV show or watch fish across a screen or do a crossword puzzle or do some other puzzle or do a coloring book or relax or maybe do a little bit of cleaning if it relaxes you. For the right individual, I point out, you described to me that you're actually not happy with some things in your life. You described that you are really not satisfied with some things at work. You've described some things in your social life you're not happy with. So that means your satisfaction level is lower than it should be. And that satisfaction level is very important about how you deal with the concept of reward. Because if you are really satisfied with your life, then you would say, well, I'm going to be rewarded now with a good night of sleep because I put in a good day. And now I'm going to get into bed and I'm going to go to sleep. But when your satisfaction is low, it's going to weigh on you and in ways that may influence what's going to happen with your sleep pattern. I will say to them sometimes, have you ever thought about getting up and doing something satisfying? And they go, well, what exactly do you mean? I say, well, it could be a lot of different things. There's no goal to overstimulate yourself, like picking up a suspense thriller novel and reading all night, because that's going to be counterproductive. But what if there was something in the house that was a minor repair that you hadn't gotten to and you had wanted to do it and you actually like making that repair under the sink and you know you can do it? What if you did get up and you did that? What do you think that would feel like? And there's literally hundreds of things like that that are small. Some people actually do like cleaning. Some people do like laundry. Um, some people like going for walks in the middle of the night, assuming it's safe. And just, yeah, I don't really get to have the time I want to myself to reflect and have that nice solitude and look at nature. I mean, there's so many things you could do by yourself, and you could get up and say, well, let me do that and see what happens. And so people can do that and they go, I'm glad I did this. This was a good thing. I wasn't in the bed doing what? Getting angrier and more frustrated. And so that's an example of how you could convince somebody maybe this is a good idea. This is very different from the instruction of do something boring. I think you can do something boring in some cases, but I have become so attuned to the fact that people are frustrated and angry and dissatisfied. I say, can you think of something you could do that would actually give you a measure of here's a little reward for yourself? You did something that made your day better. And people resonate with it and they like the idea. There are people who can misinterpret the idea, pick up a novel, read it for hours, and then ruin their whole next day for whatever reasons. They were given the instruction not to do that, but that's what they picked up. So that kind of tells you something about their nature that that would happen. But most people, when they hear this, they go, "Well, that sounds really interesting. I would like to consider that," and they think of some different ideas.
So, do you think there's something to be said about this new age that we live in, where everyone is glued to an electronic screen, and people don't have the space and time to reflect on and process their emotions? And that leads all the way up to bedtime, and then they get into bed, and the intellectual slash emotional work that they could have been doing while sitting in the lobby uh, gets scheduled in when they hit the pillow. Is this fair to say? Do you see this? Is this something worth considering or
Right. And that's so great the way you said it, unrelated to screen time. Like the screen time, people want to get into this whole thing about the blue light and the screens and this and that. And I'm not saying you can't look at all of that, but the real thing has to do with, as I've written about in before, that when does insomnia begin? First thing in the morning, right when you get up. Because from that time forward, if you're going to choose a lifestyle where you don't deal with your conflicts, don't want to reflect, don't want to gain insights from your emotions, don't want to feel your feelings, if you're going to say, I can just be entertained or I can be stimulated by a screen for X number of hours, that's what happens. You become a unfulfilled individual. You're trying to fill yourself up with fulfilling images and fulfilling memes and fulfilling discussions and fulfilling podcasts. And sometimes that can be really good and educational and so on. But if it's overdone and it's not giving you specific insights to help you grow, whether it's for sleep or something else, then absolutely that is a cause of insomnia. And of course, just the screen itself does become addicting. But the question is, why is it addicting? It's addicting because you want either the pleasure of the entertainment or you've got something bothering you and you have no other way to deal with it other than to be distracted with entertainment, whether it's a movie, whether it's music, whether it's scrolling, whatever it happens to be. The lack of emotional development in society is not only mind boggling, but deadly. And it's how we end up with a lot of things going on that um, never really are going to get corrected until people accept that we're not teaching our children to be full human beings with the idea of building character, which has something to do with learning about your own emotions.
What is the trend in insomnia? Like the genuine trend, not if it's increasing, is it increasing because it's organically increasing or because we're testing more? Is it going down? Is it pretty constant?
I don't know how good the data is on something like that because they're always saying the same thing that chronic insomnia affects no less than 1 out of 10 people. It's never any less than that. Sometimes it's a little bit more. Sometimes you see some rates that say it's higher than that. I don't know who to believe in that regard. Um, but sleep disorders in general are just becoming more evident because of the field of sleep medicine. People read about sleep more, people become more curious and interested. But then there's a whole nother group of people who don't give a damn about sleep. I mean, the president of the United States doesn't give a damn about sleep. And so you have lots of people who think sleep is for sissies. And so that's just over there. And guess what? A lot of those people are normal sleepers. So it doesn't bother them. But there are a lot of people who always had sleep disorders, didn't know what to do about it. And one day they're going to be able to see that there are some services that they can tap into and make their sleep better. But in terms of the actual rates of insomnia, I don't know anything recent that tells me that it's noticeably worse or not. You can imagine with all that goes on in the world and the fact that you're inundated with it so easily could make people more unsettled. So you might predict that insomnia rates would eventually rise.
What about comisa? Am I saying that right? Comorbid, insomnia, and sleep apnea. Can you talk about that a little bit?
I,
It's
I'd
my
rather I'd rather we do that one on a completely different podcast if that's all right.
Yeah, let's do it.
Because it goes into so many other facets that once I get started, we'd be here for another 90 minutes.
Okay, I appreciate that. Yeah, we'll come back on and do a Comisa episode. What do you think is most misunderstood about insomnia? If you had the world's ear and, including at the forefront of that, all the healthcare providers who work in sleep medicine, what would you say?
Well, there's several items, but let me just talk about the one that's most important. And that is in the mental health community, they don't really get insomnia. And it's a big problem. And it's creating worse outcomes. It's creating treatment resistance. It's creating failures of medication, all because the mental health professionals are not trained to understand what insomnia is. When they do their CME credits or CEU credits, they're not getting enough on sleep to make it practical and bring it into the clinical environment and actually do something with it. And so those individuals, and I've been preaching this for quite a while, have to understand the damage that's being done by the failure to address at the most basic level the two problems of insomnia and nightmares. Those things are really big sleep problems. They affect lots of people in mental health clinics, and they are independent disorders. And that's where the biggest problem arises that mental health professionals keep thinking you have this condition of insomnia or nightmares because you have PTSD, because you have depression, because you have anxiety. I don't know what else to tell you. Go do some sleep hygiene. Don't drink caffeine so late in the day. Uh, don't stay in your bed. Get up out of bed. Just like with a flip of a hand, just get up out of bed. Like, oh yeah, they're going to follow your instructions. They don't drill down into it. They don't have the discussions like we're trying to have right here. And they still think it's not an independent condition to treat. They still think they must be failing in their treatment of the depression, the PTSD, and so on. Instead of doing what I've taught various residents to do at times, and they've tried, and I say, why don't you say to the patient when they come in, um, today I'd like to spend some time talking just about your sleep. You know what happens at the other end of the counter, where the table where the patient's sitting? Patient sits up. Really? Really? You want to talk about my sleep? Gosh, that sounds interesting. What would you like to know? These people are dying, literally and figuratively, because people are not talking to them about their sleep. Insomnia is a huge risk factor for suicide, as are nightmares. You would think they'd be going, oh, well, you have insomnia, you have nightmares. These are known risk factors for suicidal ideation and behaviors. Maybe we should talk about these. Maybe we should spend some more time talking about these things. Even if it meant trying a new and better drug, I'd say, okay, fine. At least you're getting into the conversation with them about this. Maybe when that next drug doesn't work, you go, maybe this person needs to go to a sleep center. Maybe this person needs to go to a behavioral sleep medicine specialist. But the real damaging thing that's going on here that's so upsetting to me is that if you're a mental health professional, you're a very smart person. You couldn't be a mental health professional unless your IQ is above average and you have all kinds of skills that other people don't have because you've been trained as a mental health professional. Why don't you want to learn how to treat these sleep problems? You would be great at treating people's sleep problems. And I explain this to many mental health professionals. That you are the perfect people. You are the ones who are actually going to surpass, if that's the right phrase, the field of sleep medicine. The mental health community is eventually going to take over many aspects of sleep medicine because they're going to recognize we owe this to our patients, not to mention the fact that they have the brain power to go through all these machinations and different algorithms we've been talking about. And they could do that. Why they're not doing it is its own cultural phenomena. It's a big problem. I don't know what it's going to change that. Podcasts will have some influence. CME will have some influence, but it's just not happening yet. And that's a real shame because these mental health professionals could radically change the outcomes in their field within 1 year's time if there was this dedicated mission that said, from now on, you can't be a psychiatrist unless you take 6 months of sleep medicine courses. You can't be a psychotherapist unless you take 3 months of in-clinical experience in a sleep center working with behavioral sleep medicine specialists. If they would adopt that kind of paradigm, you're talking about a radical change in what would happen in mental health because you go to the DSM and you look at the diagnostic criteria, and it's between 80 and 90% of all the disorders have a sleep complaint. Well, what's that sleep complaint? Well, it's mostly insomnia and non-restorative sleep.
When you say health professionals, are you being specific or general here? Are you saying just psychiatrists, or do you think it would be a good idea to educate shorter educational paths to mental health professionalism in sleep medicine as well?
That's a great point because now you ask the question, how often does a primary care doctor say to somebody, I'd like you to refer you to a psychotherapist, and the person goes, no, just give me the pill yourself. And there's no discussion. So absolutely a primary care doctor, a nurse practitioner, a physician assistant would be an ideal candidate to learn CBTi. But now you're getting into another realm where we talked about this advanced stuff about emotional processing, imagery techniques. That's absolutely in the domain of a mental health professional. They're the perfect people. And in terms of a sales pitch, and this is something that's, economics often changes things. I think there's going to be a trend of mental health professionals who actually get this and they're going to catch on. I've actually seen some already, and they're going to open up their mental health professional clinic as, and we treat sleep problems. And people are going to look at that and they're going to go, oh, oh, you do depression and insomnia? Oh yeah, and we have special treatments for insomnia, not just psychotherapy. We have CBTi. We have whatever techniques they happen to learn, because there's a variety of other techniques that people can always try. And we even refer people to sleep centers if we think you need that. Mental health professionals who start doing that, they're going to start capturing larger and larger audiences. In fact, people won't be able to get into those clinics. They're going to be so filled up because the other people are disgusted and frustrated that nobody is dealing with the sleep problem. Going back, though, to your original question, a primary care doctor could do the same thing. Primary care doctor, if they wanted the business, if they were given the time, and now again, we talk about concierge medicine, but forget concierge. Just think about the fact, if my prediction comes true, I have believed for a long time primary care will eventually get out of the insurance industry. There's no reason for it. It is such a burden on the patients and on the doctors. And there's got to be an economically reasonable way to create clinics involving doctors, nurse practitioners, physician assistants that can operate on a cash paid basis. And in that environment, those individuals are going to say, well, yeah, we want more skills because the more skills we have, more people are going to want to come to us and pay. Well, this is a little bit of a specialty service. We have to charge you a little bit more for this. Person says, okay, fine. I'm very happy with this program. Primary care doctors absolutely have the intelligence and wherewithal to learn to do CBTi and more if they want to get into it. And I think that that will happen. The model right now is so constraining with health insurance and healthcare that there's just way too much limitation to ask that of people. It just can't happen.
It's my understanding too, perhaps particularly in the United States, but it feels like this is a global issue, that there's a huge lineup to get help in sleep medicine. Like there's just not enough resources and way too many patients. Is this an accurate
I
description of
think
how things
I,
are?
I think so. I see patients all over the world. I call them clients because I'm not really um, um, ordering their medical care. I just saw somebody in Israel just a month ago. He told me he got this sleep study. There was a home sleep study. He's got all the signs and symptoms of sleep apnea. He gets this home sleep study that comes back and it's normal. I said, the chances that that thing was normal or that they don't know what they're doing are very high. You're going to need to actually get scheduled in a sleep laboratory because you might have leg jerks too. And he goes, Dr. Krakow, do you know how long I'm going to have to wait to get a sleep study? Yes, I know, but schedule it anyway. You have really complex sleep problems. You're going to be working on your insomnia for months. It's a very severe case of insomnia. By the time you know it, you'll get that sleep lab study, but just go ahead and schedule it. That could be up to a year. And I've heard that from other people. I've heard that in Canada. I've heard that in places in the United States. So, yeah, services are strange because the insurance companies have tried to get people away from the sleep lab, which is a huge deterioration in the field of sleep medicine because the stuff that you're getting in the home studies is extremely limited. It's good for more obvious cases. It's not picking up upper airway resistance syndrome properly. And it doesn't really give us information the way we want it for delta sleep and REM sleep. I'm a big fan of technology. I'm sure technology will get better for these home sleep tests, and God willing, it'll be sooner than later. But that's the way it is right now.
The last question I want to ask you for this session, I'd love to have you back on, is totally tangential. But at the beginning, you're talking about Christian Guilleminault. You went and trained with him for a bit, is that right?
Mm-hmm.
Under, can you
1993.
can you talk about him a little bit? He seems to be A legend in the space. Is the reputation deserved? Why is he so
Oh,
important?
unbelievable. He was an amazing, amazing individual. I love the fact that he died in 2019, okay? And he's still publishing.
He was publishing the year he died.
No, no, no.
Oh
I'm
no,
saying,
now I say. Oh, I
I'm
see what
saying he, right. Yeah. If you go to the literature, I just looked not that long ago. I know that there was absolutely papers in 2024 with his name. I haven't looked, I don't think I've looked in 2025, but he had so much influence all over the world that 5 years after his death, he's still publishing. So that tells you a little something about him. My favorite story about CG, as we used to call him, was that when I got to meet him at Stanford in Palo Alto in 1993, I walk in the door, they're doing rounds, and I have to come upstairs and meet him with a group of people. And he says he knew I was coming for this mini fellowship. It was 3 months long. That's all I got. And he puts his hand out. I put my hand out. I say, "How do you do? I'm Barry Krakow. I'm here for the." He shakes my hand with his left hand. He grabs at the time my beard and he feels around my chin like this. I just said, "Hi, how are you? I'm Barry Krakow." And he goes, "Let's see, you have a narrow face. Your chin is kind of small. I think you have upper airway resistance syndrome." That's how we were introduced. I wrote him an email about that almost a decade later. He didn't remember it. I said, "But if you tell me, Barry, I will believe you that that's what happened." And of course, they put the esophageal monitor down me sometime later. Absolutely. I had UARS. And like any good doctor, we make the greatest patients. It only took me 9 years later before I was using PAP therapy. I used a PAP machine at Stanford one night. I had more dreams that night of sleep than I'd had in maybe a decade. What did I do with that information? Oh, I can't use this. This is really bulky and it's going to ruin my romantic life. Anyway, CG was somebody who just had so much on the ball. He had so many ideas. He was incredibly creative. And it was just a joy and a pleasure to meet him. And the last anecdote I want to mention is that he actually in 1973 was the guy who published a paper as a resident in Bologna, Italy, a neurology resident who found 3 or 5 or 6, whatever it was, patients with insomnia who had sleep apnea. And he published it in 73. It lay dormant in the scientific literature for 25 years. Ken Lickstein published a paper in 1999. We published a paper in 2001, both talking about Guilleminault's work, like, oh, there's a connection between insomnia and sleep apnea. I didn't know that. Gosh, Guilleminault published this 25 years ago. Pretty amazing guy.
Wow. Yeah, people speak highly of him. Dr. Casey Lee, who I'm sure is a name you're familiar with, also has a lot of good things to say about him. And he, along with your literature, his literature was kind of what got me started, right? Like back to the beginning of the conversation when I was kind of going, hold on a second, like this is a paper from whatever the 90s saying that actually, just because AHI is less than 5 doesn't mean that there's not a problem. Anyways, but yeah, I was
A
curious.
good, right, a good place to pick up the next conversation.